My name is Tarina Kong, and I am part of the Emergency Ultrasound Division at the Los Angeles County Medical Center and the University of Southern California. This SAEM narrated lecture topic will cover emergency ultrasound-guided endotracheal tube conformation. The objectives of this lecture are to review the indications for this procedure, to learn how to evaluate the tracheal region before, during, and after intubation, to review sonographic anatomy and landmarks, sonographic signs of a successful tracheal intubation and an unsuccessful esophageal intubation, and lastly, to review pearls and pitfalls of this procedure. In a critically ill patient, the emergency medicine physician must be able to quickly and accurately control the airway by not only performing a successful intubation, but confirming correct placement of the endotracheal tube and properly ventilating the patient. In the emergency setting, unintentional esophageal intubation can occur in up to 16% of intubations performed. Unrecognized esophageal intubations can lead to significant morbidity and mortality, and are more likely to occur in emergent conditions, so early detection methods that quickly and accurately assess tube placement are necessary in the emergency department. The indications for ultrasound-guided endotracheal intubation do not differ from the indications for any other emergent intubation. However, ultrasound can be particularly useful in patients with anticipated difficult airways due to obesity, a short neck, anterior position of the larynx, or high Mallampati scores. Ultrasound can also be used as a post-procedural adjunct for confirming endotracheal placement when esophageal intubation is suspected. The anatomical landmarks for this ultrasound application are the thyroid cartilage, cricoid cartilage, the esophagus, and the trachea. The cricoid cartilage is a ring of cartilage enveloped around the trachea. The air mucosal membrane, or AM membrane, is where the cricoid cartilage of the trachea meets the tracheal lumen. The esophagus lies posterior and just lateral to the left of the trachea. This is the sonographic image of the previous slide in a transverse plane. The thyroid is a hypoechoic arch of tissue overlying the cricoid cartilage, which is represented in this image by a hyperechoic arch. The air mucosal membrane is a second hyperechoic arch posterior to the cricoid cartilage, representing the air-filled tracheal lumen. The esophagus lies posterior and to the left of the trachea. A high-frequency linear probe should be used for this procedure. The indicator on the probe points towards the patient's right. The probe is placed anteriorly in the transverse orientation on the patient's neck at a level just superior to the suprasternal notch. Ideally, the probe should be placed on the patient during the procedure in real time. If an endotracheal intubation has been performed correctly, there will be no change in the image and only one AM interface is seen in the image. You should not see the endotracheal tube silhouette or any additional artifact once the tube has been placed. Again, this is another example of a successful intubation of the trachea. As the endotracheal tube moves past the vocal cords, you should not see any change in the ultrasound picture. Only one arch should appear before and after correct placement of the endotracheal tube. This movie shows an esophageal intubation. If the endotracheal tube has been placed into the esophagus, an additional, smaller AM interface is seen to the left of the tracheal arch. This is visualized on the right side of the screen. Now 2 AM interfaces can be seen on the image, not just one. This should be immediately rectified by pulling the tube out and attempting the intubation again. The accuracy of ultrasonography in detecting successful endotracheal tube placement has been studied in the literature. Werner and her colleagues performed a prospective, randomized controlled trial looking at 33 patients undergoing elective surgery. During the intubations, an anesthesiologist placed the endotracheal tube in either the esophagus or trachea randomly. 2 emergency medicine physicians, blinded, performed an ultrasound to locate the endotracheal tube. The sensitivity and specificity of both emergency medicine physicians on all patients were 100% and 100%. This was a small study, but it showed that emergency medicine physicians can accurately detect the location of the endotracheal tube with good sensitivity and specificity. A recent study from Taiwan called the TRUE study, TRUE being an acronym for Tracheal Rapid Ultrasound Exam, was designed to assess the diagnostic accuracy and timeliness of ultrasound-guided endotracheal tube placement during emergency intubations. The sensitivity and specificity were similar to Werner's study in correctly determining endotracheal and esophageal tube placement by ultrasound. Traditional methods used to confirm correct endotracheal tube placement include direct visualization of vocal cords, chest rise, chest and gastric auscultation, and CO2 capnometry. CO2 capnometry is thought to be the most sensitive tool and is currently recommended as the best method of confirming endotracheal tube placement. A quick, easy, and non-invasive secondary method of determining whether the endotracheal tube is correctly placed in the trachea is to perform a lung ultrasound to evaluate for pleural sliding. Simply place a linear probe over the right and left second intercostal space at the midclavicular line to assess for pleural sliding. A 2012 study by Sim and colleagues assessed the accuracy and timeliness of lung ultrasound to confirm proper endotracheal tube intubation in cardiac arrest and non-cardiac arrest patients. They found that although unilateral absence of lung sliding may not be accurate enough to detect one lung intubation, bilateral lung sliding properly identifies correct endotracheal tube placement. If there is time, pre-scan the neck with the ultrasound prior to the start of intubation. Remember that normal esophageal tissue is not easily appreciated on ultrasound. The best views of the trachea and esophagus are just cephalad and to the anatomic left to the suprasternal notch. And lastly, real-time assessment of the trachea and esophagus during the intubation is ideal when trying to determine proper placement. Static views pre- and post-intubation to visualize the trachea is an option when a single physician is both managing the airway and performing the ultrasound. Remember that anatomical variation exists, and the location of the esophagus may not always be to the anatomical left of the trachea. This may be especially true among patients with altered anatomy from neck tumors, masses, or trauma. Please use caution in these circumstances. Also, the presence of hyperechoic structures, such as thyroid calcifications, can mimic landmarks, so be cognizant of this when scanning the neck. Special acknowledgments for this lecture are to SonaCloud and Dr. Heather Bradford. Thank you.